In fact, talking about melanoma, it's a subject which is both present in the clinicals as well as the theory papers and also in your practice. So this is a big, complicated subject which you need to definitely learn before giving the right treatment. So things have changed rapidly, and the treatment also has changed. A tumor arising from melanocytes, simple. Those days we are saying about so many theories. Now it is a tumor arising from the melanocyte of the basal layer of the dermo-epidermal junction. That's the place. And what is that? This thing, melanocyte. They are in the basal layer of epidermis joining the dermis, and they are from the neural crest origin. Where is the neural crest? Neural crest is the embryo fusing the dorsal aspect of the spinal cord. The certain cells, output cells, evolve, and they go to the skin and give the pigmentation. And 5% in skin cancer, 75% skin death in whites. So it can be initiated by melanocyte getting UV rays and acting on the P53 suppressor genes. You get congenital UV rays can produce ray-induced melanomas. And as you all know, the UV rays induce malignant melanoma and basal cell carcinoma are more in Australia and New Zealand, where there is a sun ray and a slanting rays hit the face at 320 nanometers longest wavelength. So the database says there's about 90% of them occur in the cutaneous melanoma, that is in the skin. But there are instances, in fact, we operated a patient with esophageal malignancy, gastric malignancy, and gallbladder malignancy, and jejunal malignancies. All turned out to be melanomatous tumors, and they were purely done as palliative because of an advanced thing from head to foot. Leptomeninges was involved. The ocular this thing occurs in the what they describe it as the uveal tract. You have got the debris of the DNA particles. They accumulate and lift the retinal layer, and the uveal glands proliferate, and then they pass on to the regional lymph nodes. Mucosal can be in the ENT areas, gastrointestinal tract, and unknown primary sites. 7% of the tumors in the lymph nodes, if they are found to be melanomas, it is an unknown primary site, which sometimes may not be able to find out at all. And there is an interesting thing as melanoma, the soft part. It is given in pathology books, but not in clinical books. 0.5% are melanoma deeper to the deep fascia. Normally, the skin melanomas are superficial to the deep fascia. It is found that soft part melanomas occur in the deeper plane as well. They are all rarer. I think this is a quiz for students. This lady, what exactly is happening? This is published in New England Journal of Surgery. Beware of the patient with a glass eye and large liver. Anybody there? In fact, that lady had a glass eye prosthesis on the left side, and then she had the right side normal after surgery, and she developed a big liver because liver is one of the sanctuaries of melanomas. When the liver got secondaries, it became icteric, and the result is the normal eye became icteric, and the white glass ball prosthesis stayed as they white. So she had a difference in cosmetic values. Next. The differential diagnosis of skin tumors are squamous cell carcinomas, basal cell carcinomas, sebaceous tumors, hair follicle tumors, they are called as adnexal tumors. Situations like xeroderma pigmentosum, atypical familial melanoma syndromes, they're all supposed to lead on to melanoma or melanoma variety. What is a nevi? Nevi is a tag of skin, a tag of vascular tissue, tag of fibrous tissue, and it contains vascular nevi, it can contain cutaneous nevi, it can contain neural nevi, and changing of the mole sign, clinical atypical spastic nevi, large number of common nevi. They're all common nevis. Majority of them do not become malignant. This is how cutaneous melanoma, about which we are going to talk. Types of cutaneous nevi. You have malignant melanomas are divided into 4 major varieties and 2 smaller varieties. Superficial spreading is the commonest. It accounts for about 3/4 or 70%. And nodular lymphoma melanomas are 15%. Lentigo-maligna melanoma is 15%. And acral lentigens is supposed to be present in the lower limb, 2%. Amelanotic tumors and desmoplastic tumors are supposed to produce head and neck region melanomas, which are common. Superficial spreading melanoma, as you have said, I have established the diagnosis. The most common melanomas present for a long duration as levers slowly transforms into malignancy. This is how the melanoma tissue change over. This is a common exam question, Hutchinson sign. Periangual pigmentation to the nail bed. The nail matrix is completely involved in black melanomatous tissue. We call it as Hutchinson sign. Hutchinson sign is one of the in-transit metastasis because you can have a Hutchinson sign along the lymphatics from the primary to the inguinal nodes. Nodular melanoma, if it is amelanotic, if you have a doubt, the treatment is by IHC to rule out other neoplasms. See, as you see, it is red in color. There is no blackening of the surrounding tissues, but still the tissue is melanomatous tissue. So, amelanotic melanomas occurring in lower limb is common. There are various criteria for saying when to intervene and when to. One of the diagnostic criteria are nodular melanomas, E for EFG rule where Ackley-Douglas sign, ABCD criteria. They are all there for diagnosing the various varieties of changes that take place in the melanomas. Hutchinson's melanotic freckle takes a longer time for mentoring vertical phase. I'll tell you what is the vertical phase and the horizontal phase. This is typical acral lentiginous melanoma, where you have black tissues arising from the periangual plate and nail bed, and then it spreads on to the ball of the great toe. It is highly typically virulent variety of melanoma. It looked like a basal cell carcinoma, but biopsy revealed as melanoma. Microinvasive radial growth. See, the tissues which form in the skin, they spread along like in the horizontal plane, and you have a vertical growth plane. As long as the melanomatous tissue is in the horizontal plane, it goes very slowly. Vertical growth, it growth rapidly, invasive, extended deeply into the skin. This is easy to understand. The tumors on all sides along the red line, the microinvasive radial growth plane. If radial growth phase is as long as it is radial, it is slow. If it is deep penetrating, it is aggressive. The tumorogenic potential. Breslau theory, his classification comes with the vertical tumor thickness, provides the best single indicator for tumor stage. All these findings are incorporated in TM. Whether it is changing into a malignant phase, the ABCD marker is very reliable. A for asymmetry, B for border irregularities, color change is C, diameter more than 6 millimeters, and evolution of malignant change and thickening is E. So ABCDE is a very important thing to be asked, will be asked in the surgical exams. Then came the ABCDE route, simple guide for checking the early signs of melanoma. 1985 it has come. And EFG rules is for nodular melanoma, elevated, firm, growing. 3 points to tell you. There is one more thing for children, A to ABCD CUP for new lesions. A melanotic, bleeding, color uniformity, de novo, any diameter, color pink or red, changing colors, ulceration, and pyogenic granulomas can be mistaken for this. So A to P. And then there is one other criteria called as major and minor criteria. Major has change in size and new lesion, change in shape, change in color. And the 4 minor criteria are diameter 7 millimeters and less, inflammation present, crusting and bleeding present, sensory changes present. And when it comes to the question of biopsy and pathology, it is very important. The histological tumor characteristics are studied. Clark's level has been there for the subject for about 20-30 years. And level 1, in situ malignancy, invasion of papillary dermis. It goes on to papillary dermis to reticular dermis. From reticular dermis, it goes on to the subcutaneous tissue, and that is Clark's level, which also gives prognostic marker. And as per TNM 8th edition, which I was telling you, melanoma is detailed recently, 2018, I think, 8th edition. And I think you can have it. And what is very important is the nodal changes that take place and the metastatic changes that take place. You can go through it. Metastatic to skin, subcutaneous tissue, lymph nodes is M1A. M1B is metastasis to the lung. M1C is metastasis to all other visceral sites or distant metastasis at any time associated with elevated serum lactic dehydrogenase. So, investigation and excision biopsy are very important. Lymph node biopsy by FNAC or by a sentinel node biopsy or an excision biopsy evaluate malignant melanoma over 1 mm for metastasis. And early assessing margins of extent of surgery is decided by various methods, by sentinel node biopsies or visual Morse cameras, and all that have been found out. The margins is important, and the margins need not be very wide and far from the primary. What is required is 0.5 to 0.2 millimeters is all that is required. Breslow staging has taken over Clark staging for the T content. T staging. T staging is 1 millimeter or less is stage 1. Stage 2 is 1 and 2. Stage 3 is 2 and 4. Stage 4 is 4 and more. A, all situations, if the A tag is there, it is normal covered skin. B, ulceration is present. So Breslow staging is incorporated in treatment modalities. And you can have face plenty of knee-wise dermatological condition. I think dermatology is one thing so difficult to have so many 20 to 30 for a particular lesion. Seborrheic keratosis is the one which is commonly referred to as stuck stamp paper sign. That is a benign condition. And the extraocular lesions, I have been telling you, this is choroidal malignancy, uveal tract and uveal choroidal malignancy. And malignant melanoma in situ, they spread by what is called a spaghettoid spread. That is why the pathologist to learn. Starburst giant cells, it is may present at the basal layer of the epidermis. These multinucleated giant cells can contain 30 nuclei and their atypical morphology is similar to those of lentiginous array. This is also for the pathologist to read. Pigmentation of acral lentiginous melanoma, which is more common in the eastern race. Blacks are very important. Involvement of the proximal nail fold is considered a clue to the diagnosis. That is your Hutchinson sign, I told you. See, large intercepting jejunal tumor turned out to be a melanoma. It's all black in color. We thought it was initially a bowel loop was gangrenous in the interception, but turned out to be a polypoidal lesion, which is black pigmented tumors, and probably it is secondaries. Mucosal melanomas are staged according to 1, 2, 3. Clinically localized disease, regional nodal involvement, and 3, distant metastatic involvement. You can have advanced malignant melanomas fungating local secondaries in the neck. That is melanoma in this neck nodes, mucosa, and all that. Mucosal melanomas at the head of the neck are further subdivided into nasal cavity 50%, paranasal sinuses is about 15%, oral cavity is about 25%. They are people who develop it from mucosal melanoma. Then T staging, we have seen it in TNM staging. So T staging is important because it tells you the primary treatment. Histopathological diagnosis is very important. The definitive diagnosis of melanoma is a histological examination, IHC, and FISH. Evaluation of margins is important for prognosis. This is the histopathology of primary melanomas. Anorectal melanoma. This is one place which is normally given to the postgraduates at the end of the day list. And once you operate, there will be a hematoma, which is almost similar like an anorectal melanoma. Yes, thrombus piles or gangrenous piles, stage 4, they all will look like black tissue. And melanoma also will look like black tissue, one for the other, and loss of specimen, you will completely miss the diagnosis. The site of origin of the rectum and anal canal is 42 and 3% of cases, and while primary site cannot be determined in the remainder. That's how it happens. Palliative excision of anorectal melanomas are done. And if they are little relaxed, they'll ask you about neural crest tumors, apodomas, melanomas with unknown primary management, and DOPA biochemical synthesis. Because adrenaline, noradrenaline is often asked in pheochromocytes. Similarly, DOPA synthesis is asked in melanomas. Nodular melanomas, which we have shown you. Acral lentiginous melanomas. White skin population, 10% of malignant melanomas is acral. Commonest melanomas of non-white is acral lentiginous melanomas. Benign lentigo-melanoma becomes malignancy. It is transformation into malignancy. I showed you earlier about amelanotic melanomas. Here you find along the transit from the foot. It is from the heel. Invasion of the heel by a primary tumor melanomas, and then they spread along the limb, especially the lymphatics along the lungs of an sprain, and comes as a metastasis to the vertical chain of inguinal lymph nodes. And the management of inguinal metastasis, we have to do excision as if it is a lymph node. So it doesn't change the staging. Some people are earlier saying it is M. It is not M, it is N. And you find melanomatous tissue in the gastrointestinal tract. I have told you it can occur in a very rare instance. All these are 1 in million, where you have multiple tumors, melanomatous tumors inside the stomach. You can see the stomach and duodenum. You get multiple polypoidal lesions, which are all melanomas. Very rarely we come across it. It is very rare. Then, inguinal node management is very important. Palpate the inguinal transverse and vertical chain, and then evaluate with investigations the nodes present with ultrasound. And if they are positive, you need to do a ilioinguinal block dissection. Ilioinguinal block dissection is modified. The primary orthodox thing was done. Subsequently, it is modified. Then extended into the ilioinguinal tract, and then you have the external iliac, obturator, internal iliac are done for melanoma, not for squamous cell carcinoma. Squamous cell carcinoma is now restricted to a limited dissection, while melanoma it continues to be wide excision of lymph nodes. In-transit metastasis, this is very nice. In-transit metastasis is again treated as a node. Then when you opt for inguinal radical lymph node dissection, when the node is known to contain metastasis, you have diagnosed. When there is no evidence of palpable masses, prophylactic. Lymphoscintigraphy can help to identify the drainage of a nodule or use a sentinel node for biopsy. Chemotherapeutic response is 25%. And various chemotherapeutic schedules are used, but not very significantly beneficial. And radiation, it is also radiation resistant. It is useful for palliative, especially bony metastasis and brain metastasis. It is used. And palliative radiation is given for the primary. The high dose of 400 to 500 grays are used for bulky tumors. Then gastric melanoma is already seen. Ocular melanoma. What is the use of sentinel node biopsy? For advanced melanomas which we come across, it is not required. If tumor is less than 1 millimeter, for complete stage and lymphovascular invasion of the primary node, these are all seen with occult metastasis. Martin was the first in group to receive flow from tumor site, and he described the various aspects of sentinel node biopsy. So you had malignancy, then radiotherapy, then chemotherapy, then immunotherapy. Immunotherapy, you have the BRAF antigen and MEK gene and checkpoint mutations and targeted novel therapies are available. But this thing is very useful is monoclonal antibodies that are used. Immunomodulatory cytokines, monoclonal antibodies. So survival benefit is not there, but gives a better palliation. Nivolumab is a monoclonal antibody for melanomas. Latest evidence clinical potential is being described well. Local removal of small margin of normal tissue is appropriate for local recurrence or in-transit metastasis or satellite nodules. Major resections are avoided in palliative group. Never do APR, abdominoperineal resection, or liver surgeries or esophageal surgery for gastrectomies are not required because they have very poor this thing. Liver is the site of metastasis for secondaries. So hepatic resections are not advisable for stage 4 liver metastasis. So remember, when there are hundreds and hundreds of benign nevi, the ABCD of melanoma, which identifies the bad from the good, is ABCD criteria: asymmetry, border, irregularity, color variation, diameter less than starts more than 6 millimeters, and elevation from the skin surface. Thank you.
Thank you, sir, for such a crisp and detailed lecture. Any questions or comments from the audience? Dr. Amaravani, you have a question?
Yes, sir, I want to know how do you determine the depth after taking biopsy only?
Yes, yes. But they have very sophisticated biopsy snares which can be used for, because after all skin level, you can take it off, you can use it for this thickness. There are various methods to put the thickening of the specimen taken, and also you have the Mohs camera where they have a shaving of the tissues, like you get the thickness and deeper thinness specimens which are useful for pathology.
Sir, you advise the young surgeons to take a biopsy first, not the excision biopsy, isn't it?
Yeah.
You have to take a diagnostic biopsy. Depending upon the histopathology, you stage it, then go ahead for the treatment.
No, if it is melanoma of less than 1 millimeter, what it requires is only a stage 1 this thing which can be excised completely, and wait for the lymph nodes to occur in the regional nodes. So primary can be excised as an excisional biopsy.
Okay, sir. Okay.
Because you cannot do it for a lymph node, the lymph node in other places, or complicated places like the face and lips cannot be done. But in the toe, it needs an amputation. There is no other treatment for a subungual hematoma, subungual melanoma is removal with amputation.
Sometimes we do get amelanotic melanoma in the perianal region, sir.
Yes, it's very common. I showed you one picture here, but relatively it is wrong. It is rare. In a bigger institutions, people have quite number, but for an average surgeon, it is less. Mucosal melanomas other than skin are rare.
Any more questions or comments on Professor Sivakumar's lecture? If there are no more comments, sir, thank you so much again for spending a Saturday evening with us, and we'll see you again.
Thank you.
Coming Saturday. Thank you. Thanks so much.